Very good evening. I'm sure that we are not late in the session. We have a wonderful session on CTO, and this is a very a topic worth questioning by everybody whether we should do CTO or not, because there's nothing as a confirmed data which suggests that you should open the artery or not, because the risk and the benefit are always balanced on the table. So this is a very interesting topic where we're going to learn about the CTO, and we have a very good panel. And
but the first presenter is Dr. Saubhik Kanjilal, who will speak on an antegrade approach. Saubhik, floor is yours.
So good evening, everybody. Thank you, Chairman and Chairpersons. Today, my topic will be on antegrade approach for the CTO PCI. Well, as interventional cardiologist, almost everyone has witnessed so much development and improvement in the success rate of CTO PCI over the last 2 decades. Think of the success rate in almost 15 or 20 years back, when it was only 20 to 50%. But these days, it has exceeded almost 90%. Well, the reasons are many, but the most important things are the techniques and improved devices, which has helped us to gain such success. But I think the most important thing is a better understanding, the strategy which we should adopt, and the understanding of different techniques actually helped us in achieving that success. Well, among different techniques, antegrade varying is the most commonly adopted techniques in less complex cases. Well, antegrade varying means we put in a wear, we try to penetrate the cap, and we try to maintain the intraplaque status of the wear till the distal cap is punctured. Well, there are many other methods of antegrade varying as well. We'll discuss later on. And it has been found that the proper knowledge of both antegrade and retrograde approaches is very much essential to get the maximum success rate. Well, adopting hybrid approach actually helped us to gain maximum success, to make the CTO PCI safe procedure, and throughout the world, it has achieved significant importance while treating a patients of CTO. Well, the most important thing is getting a proper anatomical assessment of the CTO, and that is done by dual injection of the arteries, except in cases where we have intra-arterial collaterals or bridging collaterals. Well, while assessing the CTO, we need to understand whether some complexities are there or not. And by complexities, we mean if the proximal cap is ambiguous, if the distal target is very poor, and we also need to assess the interventional collaterals and the major side branch at the distal tip. Well, ambiguous proximal cap means the location as well as the course beyond that occluded part is not very understandable. Well, if these complexities are not there, then we can go for an antegrade approach. And for that antegrade approach, we again assess the total length of the CTO. If the CTO is less than 20 millimeter, we can adopt the process of antegrade wear escalation. Well, this is, of course, not the absolute one. We can always change the strategy midway if we think it is necessary. And if the total length of CTO is more than 20 millimeter, then straight away we want to adopt the antegrade dissection and reentry strategy, also known as ADR. So regarding the angiographic assessment, we need to assess different things before starting the process and before selecting the wear. Well, the proximal cap assessment is the most important thing to decide upon which wear we should start with. Proximal cap means if the proximal cap is blunt, then we need to have a penetrating wear with heavy tip load. Similarly, presence of calcification in the proximal cap or the presence of branches near the proximal cap again means that we need a penetrating wear. The shape of the proximal cap is also important. If we have a tapering shape proximal cap, then we may not require that penetrating wears, rather less heavy tips. Tip wears with polymer jacket might help in such cases because we might face lesser resistance while penetrating the cap. Well, the CTO body length is another important issue. As I told earlier, if the body length is more than 20 millimeter, then it's not advisable to go for anterior wear escalations. Similarly, the presence of calcification and tortuosity again will rather dictate us to go for dissection based strategies. Well, distal cap and landing zone. This landing zone means the area of main vessel which is beyond the distal cap and just before the onset of origin of major branches. If the landing zone is not proper, then the retrograde strategy is advisable. And again, the collaterals, the presence of collaterals, their courses, their caliber, their entry and exit points, all are important in assessing this strategy. Well, we need to have a proper procedural setup, as we understand that these days, most of the CTOs can be performed with 7 French guide catheters. In fact, bilateral radial access can also help in such cases. And another thing is that we need a good passive guide support. For that, for left coronary system, we can use VODA left, we can use XP or EBU. And for right coronary, we can use 3D curve right art catheters or ampullars the left. Well, regarding initial wear selection, as I told earlier, it's a very important thing to start with. We consider using a low medium tip wears to start with, of course, when there is a tapered proximal cap, when there is a longer body and there is presence of tortuosity, because using penetrating wears in such cases, like in a longer body or tortuous artery, might cause problems. Whereas we can think of penetrating wear straight away if the cap is blunt, if there is heavy calcification in the proximal cap as well as the body of the CTO, if there is bridging collaterals, if the occlusion is very short and with minimum tortuosity. Well, I'm not going into the details of the nitty-gritty of different hardwares because my next speakers will be talking about this, but these are the different types of wear from which we can choose to begin the penetration process. Well, there are some light and medium weight wears like Fielder XTs and Fielder XTR for retrograde. We can use Pilot 200. Now, these are the medium and low weight wears with polymer jackets. Whereas penetrating wears like Confianza Pro 12, Asahi wears, these are wears which are used when we encounter calcified and blunt tip caps. Well, after penetration of the cap, it is important to cross the CTO body. Well, there are different methods by which you can do. Well, after penetration, it is better to introduce or push in the microcatheter in and exchange the penetrating wear with a lesser weight wears. And this is known as de-escalation, because if you want to use the penetrating wears further down, there may be some complications, especially if the artery is tortuous. So escalation and de-escalation is a method by which you can use antegrade wearing. Similarly, parallel wear techniques, we are all conversant with this particular thing, parallel wear techniques. That means if there is any inadvertent entry of wear in the subintimal space, we can keep that wear and can take another wear over a microcatheter and try to pass that wear through the plug. And another method is antegrade dissection and re-entry. That means this is a dissection-based method, and we can use it with wear-based methods or device-based methods. Well, wear-based methods are no longer very much encouraged these days, unless if you try to bail out an antegrade wearing technique. That means if you have entered to the subintimal space inadvertently, then you can try to knuckle the wear and pass the wear through the subintimal space. But the problem with this wear-based technique is that the re-entry is not very much guaranteed. In fact, you don't have a control over the re-entry. It might go into the major branches, distal, the distal part.
Conclude,
yeah, definitely, sir. I don't have much. Yes, sir. So you don't have no control over the re-entry, but the device-based is rather more advisable these days for antegrade CTO crossing. For the device-based, we have, as we all know, the crossboss and Stingray system, as well as the recross system. And this is a recross device. This is nothing but the over-the-wire dual lumen microcatheter. It rather gives us some control for the re-entry. Well, the stingray balloon is rather more important for a dissection-based device. It needs a cross-boss catheter, which is a blunt dissecting catheter, which passes through the extra plug intima in a controlled dissection manner, and it helps to deliver the stingray balloon. This stingray balloon is actually a flat balloon, 10 into 2.5, with two exit ports at the tip. Now, before re-entry, we need to align the stingray balloon so that the exiting wire does not puncture the adventitia. For that reason, we need to collinear, make the 2 points of the exit and the surface of the balloon in a collinear plane. Well, this is a video which shows how to proceed with this crossboss and stingray technique. Now, the crossboss catheter is passed extra plug through the subintima till the distal cap is pierced. Then we remove the crossboss catheter, we deliver the stingray balloon, we inflate at 4 atm pressure and try to bring in the stingray wire. This stingray wire is a micro bulb at its tip, and this wire usually tries to cross the distal lumen. But if there is a significant atheromatous plug between the exit port and the distal cap, then we can use some penetrating wires like confianza. Well, after the distal wire is delivered, we try to exchange this wire over the microcatheter, and a workhorse wire is placed in place of it, and the remaining part is carried out in a normal manner. So these are the different methods of, in a very short and in very simple way of antegrade CTO technique. Well, my take-home messages will be that there has been advances in different equipments and techniques that has led to the success, but we need to be familiarized with these specific techniques and equipments and understand which technique is used in which situations. Well, anterior wire technique remains the predominant strategy for the CTO of less complex lesions, and many CTOs can be dealt with dissection-based strategies, especially these ADR-based strategies can offer a very safe and efficient means in selected patients. Thank you for the patient sharing.